Good morning, everyone, and thank you for joining us for the Medical Board of California's Interested Parties meeting on licensing application questions relating to mental and physical health. Public comments will be welcome following the presentations by the speakers. To be ready for public comment, we ask that you please ensure your comments can be heard clearly by being connected to the audio of this meeting through the proper method. If you're having difficulty hearing the audio of this meeting, it could be because the device you're connecting with has bandwidth limitations. If you do have difficulty hearing the audio of this meeting using your device, please click the ellipsis button at the bottom of the WebEx application or the audio and video menu item at the top of the WebEx application, and then select Switch Audio. You will see an option to call in and will be provided with a telephone number, access code, and attendee ID that can be used to connect your device's audio to, excuse me, to connect to the meeting audio via phone. Using the information provided will automatically disconnect your device's audio and connect your phone to the name you joined the meeting with. By using this method, if you're having audio problems with your device, this will allow you to still participate and hear the audio of the interested parties meeting. Please see the instructions on how to connect link on the last page of the meeting agenda for step-by-step WebEx instructions, including screenshots. Thank you, Ms. Zhang and Dr. Tsai. You can now start the meeting.
Morning, everyone. My name is Nicole Jung, and I'm a public member of the board. We want to thank everyone for joining us today for this interested parties meeting to discuss licensing application questions related to mental and physical health.
Good morning, everyone. I am Viling Tsai. I'm a physician member of the board. I'm looking forward to today's discussion. The board last updated its licensing application questions relating to mental health and physical health back in 2019 to limit the inquiry to current enrollment and current enrollment participation in a monitoring program and to current mental or physical health conditions that impairs the individual from being able to practice medicine safely. California, along with 26 other states, has been recognized by the Dr. Lorna Breen Heroes Foundation, a national organization dedicated to promoting physician well-being, for changing invasive and stigmatizing mental health questions in its licensing applications. That being said, the board has heard from interested parties that the current questions may discourage medical students, residents, and physicians wishing to practice in California from seeking mental and/or physical health care to avoid having to answer yes to any of these application questions, and that the questions stigmatize such health conditions.
Board's primary mission is to protect consumers. So today we are going to hear from speakers across the country who share that mission on different approaches for addressing impairment issues on licensing applications. Our plan for this meeting is that we will introduce our three speakers. They'll give their presentations and then we'll open it up for public comment. Our first speaker will be Mark Statz, the Chief Learning Officer at the Federation of State Medical Boards, the FSMB. In this role, among many other things, he's responsible for overseeing educational programming and initiatives, developing organizational policy related to medical regulation, and supporting the FSMB's work in ethics and professionalism.
Our second speaker will be Dr. Janelle Ryan, who is the Director of Innovation, Policy, and Strategy for the North Carolina Medical Board, and has a long history of service in medical regulation. Among other things, she previously served as a physician member of the North Carolina Medical Board from 2003 to 2009, also having served as president of the medical board. Additionally, she also served on the board of directors of the Federation of State Medical Board and also has served as its chairman of the board.
Our third speaker will be Stephanie Luca, JD, who was appointed as the Executive Director of the State Medical Board of Ohio in November 2019. In her role, she oversees the operations of the board, provides guidance to the 12 members of the board and serves as the board's liaison to the governor, legislature, and many other stakeholder groups. Prior to her current role, Ms. Luca served on Governor as the director of the Ohio Department of Aging. She also served as chief of staff and the state's chief human resources officer at the Ohio Department of Administrative Services.
We welcome each of our speakers and thank them for sharing their time and their expertise with us on this important topic. Mr. Statz, welcome. We're looking forward to your presentation. Are you ready to proceed?
I am, yes. Thanks very much.
Thank you.
So thanks very much for that introduction, Ms. Zhang and Dr. Tsai. It's a pleasure to be here speaking with the Medical Board of California, as well as members of the public, about an issue that has been central to a lot of the Federation of State Medical Boards work over the last several years, since really at least 2015, but even as far back as 1990 when the Americans with Disabilities Act was enacted. So again, happy to be here speaking about it today. We can go to my next slide, please. So I'll say a few words about the FSMB and who we are and who we aren't really, and then give some background and context about our discussions on licensee well-being and how the work of state medical boards can intersect with that. We'll talk about the FSMB's recommendations in this area, what other states have done since our policy on physician wellness and burnout was approved in 2018. And then I'll finish by talking a little bit about California's current application questions and offer some suggestions for how they might evolve. Next slide, please. So the FSMB's purpose really is to support state medical boards across the US and in its territories. We heard Ms. Zhang talk about the mission of the Medical Board of California as protecting the public within that state. We exist to support that type of mission among our state medical boards. We don't, however, regulate anything directly ourselves. We only support regulatory work. So we can't mandate anything or require anything. We can only look around the country and around the world and discover what best practices might be, combine that with evidence from academic literature or elsewhere, and then make recommendations to state medical boards in the US. Next slide, please. And we support boards in a variety of ways through products and services related to issues around licensing, discipline, or credentialing. We also co-sponsor the United States Medical Licensing Examination to ensure that licensees at the initial points of licensure would be prepared to practice safely. And we also offer advocacy, policy, and communication support. So I think this presentation today falls pretty squarely in the first bullet there around policy advice that we provide to state medical boards. Next slide, please. Just a brief hello from our board of directors. They're quite involved in our work and help us with direction because they all represent state medical boards as well as the public in their various jurisdictions. Next slide, please. So our work in physician well-being and burnout. In 2015, the FSMB's Ethics and Professionalism Committee held a meeting to discuss how to provide guidance to state medical boards around disruptive physician behavior, core medical regulatory work, and there was and still is a need for support in a variety of ways around disruptive physician behavior. But when the Ethics and Professionalism Committee held its discussions about this issue, it quickly became apparent that many of these instances of disruptive behavior that were being discussed had their roots in either situations of burnout or various forms of impairment arising through illness. So that Ethics and Professionalism Committee quickly pivoted and said, we need to address these roots before we can actually address the rest of the issue. And there was recognition also that there needed to be a focus not only on individual responsibilities of physician licensees themselves, but also of the system factors that might impact whether circumstances of burnout or that might impact an ability to seek treatment for one's illness and potential impairment as a result of that illness. The FSMB decided to create a work group to study the issue, and that was the work group on physician wellness and burnout. Next slide, please. That work group was influenced initially by earlier research that examined the presence of questions addressing mental or physical health on licensing applications, but also on examinations of the applicability of the Americans with Disabilities Act to those licensing applications and the phraseology of the questions on those applications. So the first article here did a survey of the number of applications that actually had questions related to mental or physical health and assessed whether or not they might contravene the Americans with Disabilities Act. So at the time, I believe it was 47 of 52 applications reviewed had questions about mental health. That number actually increased following the publication of this application. The year after, that number was shown to increase, but it also contained more of an examination of the impact of these questions on the licensees themselves. And this was, to our knowledge anyway, one of the first publications to identify the fact that licensing application questions could actually dissuade a physician or an applicant for licensure from seeking treatment for those conditions. That thesis was supported and actually confirmed through a study from 2016 where Dr. Katie Gold used a very large Facebook group of physician women to survey them about their reaction to those questions, and actually had questions about whether or not they did have diagnoses of various types of mental illness. This confirmed that there was a significant reluctance to either seek treatment or, if treatment had been sought, to report it accurately on licensing applications. So this told the FSMB, and also I think it told a lot of state medical boards, that you may have a certain intent in mind when you include a question on your application, but the way that that question is answered is not necessarily up to the board that asks it. Next slide, please. This is a sample application from 2018 when our policy was adopted. Our focus then again was more on the Americans with Disabilities Act and issues that might arise if an application was challenged in court. So on this application, you see a lot of language around an infinite look back into a licensee's past about substance use or about previous diagnosis. You also see a lack of a distinction between a distinction between mental and physical illness that could arise, that could give rise to impairment. And so this would have been considered a problematic application. Fortunately, it has changed. This is not from California, it's from a different state. It has changed, and we've seen nearly every state medical board application change to move away from language having these infinite lookbacks to either within the last couple of years, or do you currently have an impairment that limits your ability to practice medicine safely. Next slide, please. So again, our policy did focus quite a bit on the Americans with Disabilities Act, but it had 35 recommendations. It has 35 recommendations, which at the time was the most recommendations the FSMB has ever made in policy in its more than 100 years. Not all the recommendations are focused on state medical boards and actions that they could take to improve the health of physicians and therefore the safety of the care that they're able to provide. Many of the recommendations focus on other entities or organizations with a nexus to physician well-being and physician health. So, the medical education community, the hospital community, given systems factors that could creep into the ability of a physician to be well, and really other areas where there might be a possibility to address the stigma associated with health conditions. Next slide, please. So the goals of the policy, again, were heavily related to that stigma. There was not a lot of conversation going on in 2015 through 18 when this policy was being developed about mental health. It's not necessarily a topic of conversation that comes up often, especially if someone suffers from a condition that they feel might limit their ability to practice medicine, to earn a living, really, or to follow a career path. So again, the focus of the policy was really around that stigma and encouraging help-seeking or treatment-seeking in the face of that stigma. Another important goal was to clarify the role of state medical boards as not always punitive. So while we do live in a system that is complaints-based, state medical boards perform a lot of roles that aren't necessarily related to disciplinary actions. Some of them are about communicating openly to the public about issues their licensees are facing, about the disciplinary history of licensees, but also communicating with the licensees themselves about ways in which they might seek help, be safer providers, and be healthy providers in order that their patients can receive care that is safe and appropriate as well. Next slide, please. So the first recommendation of this policy did relate to licensing applications. And the recommendation was to evaluate whether it's necessary to include probing questions about a physician applicant's mental health, addiction, or substance use. This, to many, seemed at the time and still seems counterintuitive to some extent. To remove questions about these very issues that might actually pose a threat to patients didn't seem like the work of state medical boards. State medical boards need to know this information in order to help protect the patients in their states. However, it took a lot of effort, and it's still taking a lot of effort to convince people that a healthy physician is a safe physician, an unhealthy physician, or a physician suffering from impairment is not a safe physician, and that asking these questions could actually prevent a physician from being safe and healthy. Next slide, please. There were several other recommendations included, as I mentioned. Many of them focused on destigmatization, but also ADA compliance. So distinguishing illness that a person may suffer from impairments that could result from that illness. And I think that distinction pertains still to California's language on its application. Providing confidential non-reporting options to physicians so that they may seek treatment for conditions that they face, whether or not they're impaired, and receive the treatment that they need in order to practice safely, but not have to report that on licensing applications, thereby removing a barrier from seeking the treatment itself. Non-disclosure of a licensee's personal health information, because this information might be important in contexts where impairment has arisen and is known by the state medical board, but to protect physicians from having that information disclosed more broadly. And again, that can re-stigmatize the issue and cause additional licensees to avoid seeking treatment. And then finally, maintaining a relationship with a physician health program. Physician health programs are central to physician well-being, and they're also central to patient safety. California is in a bit of a unique position. It does not have the same physician health program resources currently that many other states have. Although several resources do exist within the state that are being used by licensees, there isn't necessarily the same physician health program model that exists in most other states across the country. However, it's important to understand what that model involves and how the types of resources explained in that model and borne out by the evidence as helpful to physician health and patient safety could be used and accessed within California. Next slide, please. So we've seen progress since 2018, significant progress, not only on compliance with the Americans with Disabilities Act, but on fairly significant changes to licensing applications to either remove questions altogether or to change the language of those questions to attempt to destigmatize the issue, to point to existing resources within states, and again, to encourage treatment seeking. What we've seen in some instances is rather than removing the questions altogether, some states, and you'll hear about one of them shortly after my comments, have moved towards what's being called an attestation model, where the responsibilities of a licensee to seek treatment in the face of potential impairment are clarified for licensees, and the licensee would have to check a box or in some way sign to attest to the fact that they understand what those responsibilities are, and that they would be held accountable if they did not fulfill those responsibilities. Next slide, please. So Dr. Tsai mentioned already that the Lorna Breen Heroes Foundation recognized California last year for its changes to licensing applications and compliance with FSMB recommendations and Lorna Breen Heroes Foundation recommendations. You'll see that there's a lot of burgundy on this map. So many states have done the same and made quite a few changes. A lot of the states on this map, which is the current map on their website, but actually I think if they could update it, they would change several of the teal states here to burgundy as well, because the majority of states now have made significant changes to either remove questions or move towards this type of attestation model or friendlier language that helps physicians feel willing to seek treatment. Next slide, please. So we'll talk about California's application as my last couple of slides before my comments are finished. This is the sort of the preamble to the questions that I'm displaying here. I don't necessarily think that this language is problematic, certainly not from an Americans with Disabilities standpoint. However, it might still have a chilling effect on licensees and prospective licensees who are worried about what a restriction on their ability to practice or a license limitation could mean for them and for their careers. So, I think, again, if questions are changed towards more of an attestation model, this statement might not be necessary, but could instead highlight the types of resources that are available and ways in which physicians might be able to assess and seek treatment for their health conditions. Next slide, please. These are the three questions. These are quite close to the language used in FSMB's recommendation, particularly the second question here. The first question I'll come to in a moment, but the second question asks, do you currently have any condition that impairs your ability to practice medicine safely? FSMB's recommendation bakes in this type of non-reporting option directly into the language. So our recommendation is, do you currently have any condition for which you are not being appropriately treated, right? Or for which you are not seeking treatment that impairs your ability to practice medicine safely? The feeling there of our work group and of the FSMB in its policy is that if the person is being treated and they are not at risk of impairment from their illness or the condition they're facing, then they should not need to report that on the licensing application. The third question here, I would argue, is a bit redundant with the second question, right? This could ask about conditions generally, does not necessarily need to list emotional, mental, neurological, or other physical, addictive, or behavioral disorders, could just talk about health conditions, because health conditions of all sorts could be potentially impairing and may require treatment or support. And then again, the first question, being enrolled in a recovery program, or I would call it a physician health program or physician health and wellness, or even a peer support program rather than an impaired practitioner program, because not only do impaired practitioners seek help there, but also people with the potential to have impairment through an illness might seek help. But that question could be eliminated or become a corollary to a yes answer to the question about whether an illness is present. So I'm almost finished, but before I stop there, I just want to say that, again, this does seem counterintuitive from the perspective of state medical boards. It also may seem counterintuitive from the perspective of the public to remove questions that might be helpful in determining how safe an applicant for licensure might be to treat patients. However, what we've heard through discussions with state medical boards and on surveys with state medical boards and in our interactions with our members is that if these questions are posed on licensing applications, they'll often result in one of two things. Either the physician will avoid seeking help and continue to practice and potentially imperil patients. They'll avoid seeking that help so that they don't have to report it on their licensing application, or they'll lie on the licensing application and they'll report that they have not sought treatment. They might be safe because they've been treated appropriately, but the licensing board or the medical board still won't receive the information that it's hoping to elicit through the question. So our recommendation again would be to focus on information about professional responsibilities and ways in which help, support, or treatment for potentially impairing conditions could be sought in the state. And we can move to my last slide, which is, again, a thank you slide. I appreciate the opportunity to be here. Would be happy to answer any questions or to help continue to work with the Medical Board of California on these important issues. Thank you.
Thank you, Mr. Satz. Very interesting presentation. I think what we'll do is if we have any questions, we'll hold it till the end. So we're going to proceed. We're now hear from Dr. Ryan regarding North Carolina's change to an attestation model regarding impairment. Dr. Ryan, are you ready?
I am. Can you hear me?
Yes, we can. Go ahead and
Okay.
proceed. Thank you.
Okay, thank you. So thank you very much for that introduction and for the opportunity to speak today about the North Carolina Medical Board's experience regarding the mental and physical health questions on our license. Next slide, please. Just a disclaimer here. I wanted you to know that I kept apprised of what was going on, but I was not on the medical board when the change was made back in 2017, nor was I staff at that time. Next slide, please. So why did we make this change? There was a very prominent medical leader who was a non-physician in North Carolina, and he was just devastated when his much beloved primary care physician took his life by suicide. And it was reported to the medical board that the physician's spouse made the statement that her husband was hesitant to seek help due to concerns over losing his license. And so this medical leader, who was not part of the medical board, really galvanized this effort to try to change the licensing question. And this was back in 2017 that the change was made. So it was pre-COVID. It was before a lot of this discussion about physician health was discussed. Next slide, please. So before we changed any questions, first of all, we wanted to look at our available data. And we realized that after reviewing several years of responses to our question 4, which is the physician health question, that we weren't really collecting useful information. And at this time, burnout and physician suicide was really being discussed, not only statewide, but nationally and internationally. And so we were disturbed about that. And we looked at our licensing application again and thought, well, maybe we're deterring physicians from receiving help and seeking help. So next slide, please. So pre-2017, our question number 4 reads, since you last renewed, have you become aware of any medical condition that impairs or limits or could possibly impair or limit your ability to practice medicine safely? If you're an anonymous participant of the North Carolina Physicians Health Program and in compliance with your contract, you do not need to list any medical conditions related to that contract. And the board decided that medical condition would include physiologic, psychiatric, psychologic conditions and disorders, including but not limited to orthopedic, ophthalmologic, or neuromuscular problems, speech or hearing impairment, or infectious disease. Next slide, please. Now you'll see that this is our attestation. It's not a question, it's an attestation. And there is a checkbox, and you check the box if you attest to it. And the reason it's bolded here in the slide, or parts of it are bolded, is because that's how it is on the actual application. What's bolded here is bolded on the actual application. So looking at that attestation, it reads, the board recognizes that licensees encounter health conditions, including those involving mental health and substance use disorders, just as their patients and other healthcare providers do. The board expects its licensees to address their health concerns and ensure patient safety. Options include seeking medical care, self-limiting the licensee's medical practice, and anonymously self-referring to the North Carolina Physicians Health Program. And that program is a physician advocacy organization dedicated to improving the health and wellness of medical professionals in a confidential manner. The failure to adequately address a health condition where the licensee is unable to practice medicine with reasonable skill and safety to patients can result in the board taking action against the license to practice medicine. So so you see what we changed it to, although it's called question 4, it's really attestation. And we have been with this question since 2017. So next slide, please. We were asked, the North Carolina board was actually the first board, I think, to have the attestation, and one of the first boards to recognize these changes on the application. And I suspect that's why we were asked to talk, not only to you, to the Medical Board of California, but we have another talk that was delivered this week. So we got together to think about, well, how we really haven't evaluated, are we making a difference? And we looked at the questions that we thought we needed to look at to evaluate the change. Did that old question 4 discourage physicians from getting help? And did removing question 4 encourage doctors or physicians to get help? And how should we measure? What parameters or what are we looking for? Are we looking for more physicians getting help? Are we looking for a decrease in reported depression and burnout, or fewer physician suicides? And how do we collect that information? I'll tell you, it's very, very difficult to collect information on physician suicides. Unless someone tells you, you really don't know. And also recall, COVID is now a factor, because we've gone through COVID now, or it's resurging, but COVID was not around in 2017 when we started this process. Next slide, please. So since we didn't build in any research at the time the question was dropped and the attestation model was adopted, we really had to do a retrospective study. So in the past few weeks, we've tried to do a retrospective analysis to see, are we seeing any results from this change? So we looked at our very recent North Carolina Physicians Health Program study on suicidal ideation among the physicians in North Carolina. We had that. We looked at anonymous participation in PHP since we removed question 4, because we were curious to see, has that participation changed? And then we do periodic North Carolina Medical Board license survey of our licensees. We have one from 2018 when we had just started this new model, and we have one from 2023. Next slide, please. So if you look at the preliminary results of the NC-PHP Suicide Prevention Initiative, which was a descriptive cross-sectional correlation design study, the data was collected with online surveys. You see, we had 1,416 respondents to this survey, 48% female, 52% male. The average age was 52, with the time working 21 years. So this is a seasoned group, and they're also working more than 40 hours a week. obviously we were a little disturbed when we looked at that suicidal ideation of 17.5%. There was a 2022 Medscape study that looked at suicidal ideation, and their numbers were lower at 10%. Now, I will tell you that we don't have that suicidal ideation from before or after 2020, from previous years or subsequent years. So we really don't know how it fits in. And also with the Medscape study, they had over 9,000 participants in their study. They had 9,175. So it's a little hard to make comparison there, but it is disturbing. So we decided, well, let's look at the number of anonymous participation in our state physician health program. Next slide, please. Well, the anonymous participation actually did not increase in PHP. And as we were scratching our heads to find out why it didn't increase, we thought about COVID. And also we realized that there are more local options available now, and some people would rather get help locally than travel to one central center. So next slide, please. That's just, just shows you that the anonymous participation has dropped since 2019. So we looked at our slides from our 2023 Medical Board Survey. Next slide, please. And that question that was asked was, have you sought help for your, have you sought any professional support beyond self-care to address burnout or occupational stress? And what types of professional support have you sought? And you see it on the right side. There were 33% sought professional health. Majority of this was behavioral health, counseling or therapy. But we see where people are utilizing their employee assistance program at their place of employment, as well as coaching. So even though the North Carolina Professionals Healthcare Program was not one of the top ones, there again, we think people are looking local for help, and this knowing that they can get counseling or therapy locally, and they've got the EAP there. We think, or I think that has something to do with the anonymous rates going down on PHP. Okay, next slide. So in our 2018 Medical Board Survey, we asked the question, does changing the question on the annual renewal make a difference in your willingness to pursue treatment? And there was some concern back in 2018, which was 1 year after we started the survey, that still there was concern that this would be looked at negatively and could possibly impact the license. However, other respondents said, well, I need to get the help. I need to be healthy for myself and my patients. So that was interesting. So remember that number, 32%, and we'll look at that number in the next slide on the 2023 Medical Board Survey. If you can go the next slide, good. So there it is, that same question. We went from 32% to 40% said they would be more willing to pursue professional support. And if you look at the comments that were written in, we were encouraged to continue to eliminate questions regarding to substance use and streamline questions that only are truly necessary for safe patient care. And the second comment, in the stigmatization of mental health for physicians, removing the questions are a good first step. And then the last comment, one of the largest barriers, again, is fear of the medical board taking action. So if you look at the next slide, please. We ask actually in that survey, what are your barriers to seeking support? And actually the first barrier in the 54% was time, which there again goes along with burnout and everything else that we're seeing now. But still almost 20%, 19%, there's just this fear of repercussions from the medical board or limiting the ability to practice. So we still need to work on that. Next slide, please. So what conclusions can we take from our experience changing the question? Well, first of all, we really can't make any conclusions. I think you've heard that we didn't design this as we made the change, and we really had to look at retrospective data that we have. However, and then we had the COVID, which certainly caused changes. Other states, though, may well have a different experience. We don't mean to say that all states will have the same experience with than us. As you know, if you've seen one medical board, you've seen one medical board. They're all slightly different. I know for a fact, and I think you've heard, that Washington has a very good PHP program. They may have different numbers. So if you're contemplating a change, consider what, if anything, you want to accomplish. And this is what we're seeing retrospectively. Are you trying to encourage your physicians to get help? Are you trying to reduce the stigmatization that may occur by asking the question? Are you trying to reduce administrative burden? Are you trying to do the first three of those things? And are you getting useful information? And then next slide. What has North Carolina done since this topic arose and since we've been talking about it? Well, number one, we established a wellness statement. And then we have published wellness resources for clinicians on our board's website. We've given podcasts on the same subject. And speaking of Lorna Breen, we actually are a badge holder from the Lorna Breen Foundation's First Champion Challenge program, the Wellbeing First Champion Challenge program, and actually just submitted our application for continuing champion. So we participate in this North Carolina Clinician and Physician Retention and Wellbeing Consortium, which is a consortium that includes the healthcare organizations in North Carolina. And we're working with the Dr. Lorna Breen Heroes Foundation. Especially right now, we're working on the All-In Caring for North Carolina Caregivers, which is about changing the license question on credentialing applications. We've been working with our State Department of Insurance and had meetings with them to make sure that it's not just the licensing board, but it's other entities, whether it be a hospital or a health system, that are also credentialing. Thank you very much. That's it. Thank you for the opportunity to speak.
Thank you, Dr. Ryan. We now welcome Ms. Luca regarding Ohio's change to their impairment questions. Ms. Luca, are you ready?
Yeah, thanks so much for having me here today. I'll just preface this by saying I had a little dental work done this morning. And so if you can't understand me, just ask me to repeat and we'll get through this. Okay. So again, thank you so much for having me here today. I will say that we built a lot of what I will talk about on the work that the FSMB did years ago, as well as some of the work that North Carolina did amongst medical boards. We frequently borrow from each other when we're trying to think about new changes. And so we're happy to share today where we are with the topic on the table. I would say also that we are really early in this journey. We just started making changes in 2023. So what I'll talk about is relatively recent. So you can kind of think about it in a continuum of FSMB kind of kicking things off, and then states sort of adopting and adapting some of those policy recommendations. So today, where we started, you heard Dr. Ryan talk a little bit about the North Carolina data and sort of what prompted their journey. Very similarly in Ohio, our PHP program, the Ohio Physicians Health Program, did a survey it's sort of toward the tail end of COVID. It's about 2021, 2022. And it was a survey focused on burnout. And they surveyed every licensed health professional in the state, and then broke that down by category for each of our different healthcare licensing boards. We had about a 25% participation rate at the state medical board. And what we learned from that data was very similar to what Dr. Ryan was just explaining. Our providers were feeling very burnt out. They are overwhelmed. They weren't feeling recognized. And one of the key things that we felt was an action item for us in that survey was relative to why don't you get help? And interestingly, our numbers look very similar to those data points that Jan just shared with you. About 50% of them said they just didn't have the time. But what was alarming to us, and almost right in line here with North Carolina, was that 36% of them feared confidentiality from the board. And so we interpreted that to mean, right, that if the board found out that they would be then punished for any sort of impairment. And so that really started a conversation with our PHP at a staff level that we then worked with PHP members and brought that to our state medical board as a presentation to our members to explain that we think we have an obligation here to address some of the concerns of our licensee base. Next slide, please. So we, at that point, really dove into a comprehensive, what I would call overhaul of what we consider our confidential monitoring program, which is really our work with our PHP. And so that was a 4-part plan. We expanded the work of what could be considered confidential with our monitoring program. We also transitioned some of our post-board order work. So when things did become public, we transferred that monitoring over to our PHP. We also transferred the management of our treatment provider network over to the PHP. And then the 4th part that we're here to talk about today, it was really foundational. It really should be the first block on this slide probably, was the change in the licensing question that we did in Ohio. And so next slide, please. So this is our licensing question from that predates our work that for our overhaul that we did of our monitoring program. As you can see, it's very long, it's very dense. And we, at that point in time, had a 5-year look back question. And we asked about, by that point, we had an updated condition to include both physical and mental conditions. And we did say too that you could answer no if you were in what we then refer to our program as a 1-bite program. At that point in time, our 1-bite program was just what it says. You had one shot at confidentiality. So you had the opportunity one time in your professional career to go to the PHP and remain confidential from the board. If you had any sort of relapse, or if you had any sort of straying from the monitoring plan, the PHP had to report the individual back to the board, and then public action could be taken. It wasn't always, but it could be. Of course, the concern with this is that that's not how impairment works. And relapses do happen, and we know this scientifically. We know that people can still safely practice with either monitoring or treatment. That a relapse is not a disqualifier to a safe practitioner at some point in time. And so this one bite program really was starting to also feel very much like the deterrent that our licensing question is. And that is that people were sort of afraid of messing up. It was really kind of we were hearing very much from licensees and frankly, even from the defense counsel who represented them before the board, that we were sort of creating this hunker down culture that people were not coming forward. Next slide, please. I included the next two slides for you to just illustrate how detailed we became with the questions that we were asking prior to our overhaul. We got into a lot of very specific questions about what this limitation or impairment was doing and how it was really sort of playing out in the life of the practitioner. So these are just examples. This is just a continuation of if you answered yes, this is what else you would be answering. Next slide, please. Again, all of these questions. And so you will be surprised to know, I don't think you will be surprised to know, that during the course of time, we looked at 2 years of data on our licensing questions, and we did not have anybody tell us yes to any of these questions. And so we know that is not reflective of what is happening in the real world. We knew based on the survey data, right? We had these two different data points. We had people telling us how overwhelmed and how very burnt out they were. And then we had people telling us, no, I'm fine. I don't have an impairment. And so this kind of follows back to, it's a good illustration of what Mark was explaining, that we really had to take a hard look as a board to say, our role is to protect the public. And while it may seem like information gathering and the license application is protecting the public, the actual impact of that was that we were making people not come forward, not seek treatment, and really practice unsafely, most likely. They were hiding from their employers and from the board. And so we actually thought that was opposite to what our mission is. Next slide, please. Oh, one back. There you go. Okay, so in our budget bill of fiscal year 23, so that was July 1st of 2023, we implemented our whole new program, including a new licensing application question that asks if you're currently suffering from a condition that impairs judgment or would otherwise affect your ability to practice. And condition means both physical and mental, including substance use disorder. This was actually, like I think I mentioned earlier, we had just the year before included mental and physical in this question. You can answer no to the question if you're currently working with our Ohio Professionals Health Program. This licensing question is also provided to our resident trainees. So that was not an option that was available prior. And it's also available to new applicants in Ohio. So prior to the implementation of this question, if you were a new applicant in Ohio, you could not take advantage of the One Bite program. You had to come to the board first. And so it was just a really, we had sort of created logistics that really painted ourselves in a corner with respect to how we were able to help people navigate treatment and then future monitoring. But I think what's really interesting too, that we did as part of this question that we implemented was really the physical part of impairment as well. And so we're an aging state. Ohio is aging rapidly. We have a lot of physicians who practice well into their 70s, into their 80s. And we know that sometimes, and then the only way also to not be licensed in the board in Ohio is to surrender your license. You, even if you don't renew your license in Ohio, the board still has jurisdiction. And so we wanted to provide a sort of a human approach to practitioners as they age, being able to approach our physicians health program to say, will you work with me? What kind of monitoring, what kind of supports can I do to safely practice? And also to have the PHP be able to confidentially work with a practitioner to step out of practice when that time comes. And so as part of this, we also created a new retirement status at, as part of our overhaul initiative, that would let the PHP sort of guide the practitioner back to the board to permanently retire their license. So next slide, please. This data is we think, again, to Dr. Ryan's point about what matters, right? So right now we're sort of looking at what I would call demographic data, right? Like who's participating. We're working closely with our PHP to define outcome measures, and as addition to sort of this output, what we would call output measures. And so what we do know is that our participation in our PHP, what we call the confidential monitoring program, has increased tremendously. These numbers are from the first 3 quarters of implementation of the program. I just got the numbers today from the last quarter, so I didn't feel comfortable providing those without asking a couple of questions, but they're right in trend with these numbers. They've dropped a little bit, but not enough to really note. So we do know that our non-board referrals have increased tremendously in just year over year with the implementation of all of our changes. I really, one of my takeaways from this call, so this, we do this so that we can all learn from each other. And I think that we're probably headed toward a survey of our licensees to see how much that application question change has impacted their participation in confidential monitoring, or their thoughts about confidential monitoring, kind of their thoughts about the board, and are they more likely to seek treatment with that question change in there. Again, thank you so much for allowing me to be here today to talk with all of you, and I'm happy to do any follow-up.
All to our speakers for your generosity and sharing your information and experiences with us today. I think we all feel fortunate that we're able to hear from your experiences and all the extensive research. A great guiding point for us. So now we can move on to agenda item number 2, public comments. Dr. Sai?
All right, thank you again, speakers. I was taking notes, so I learned a lot. Now we move on to agenda item number 2. We are looking forward to hearing from individuals who want to speak during this meeting. We ask that you please keep your comments on topic of whether the board should change its introductory statement and/or questions relating to mental and physical health on its licensing applications. The introductory statement and questions are included on this agenda for this meeting. Please keep your comments to about 3 to 4, 3 minutes or less, because I think time is as of the essence. So Sean will be the moderator. Go ahead.
Thank you, Dr. Sai. For anyone wishing to make a public comment now, you can go ahead and use the hand raising feature. I saw some folks doing that during our presentation. So if your hand's still up, we will call on you. If you're having trouble using the hand raising function, you're welcome to use the Q&A window as well. You can type anything in there. You don't have to type your entire question. You can just, type, I'd like to make a public comment or anything simple like that. And then also anyone who may have dialed in on a phone-in only line, there is an option to press *3 if you're on a call-in only line. That will toggle raising your hand on the call-in only lines. When called upon, I'll call upon you by the area code that I see on your phone number, and you should hear a verbal prompt to press *6 to unmute then. So up here, first we have, and I will also be giving everyone a verbal prompt with 30 seconds remain, and then when your 3 minutes has expired, please conclude. So, Jennifer Nagode, you're the first one up here. Go ahead and sending a request to you to unmute. Good morning, Jennifer. We can hear you. Please go ahead.
Can you hear me? All
We
right.
can.
So, so I'm a physician, I'm a psychiatrist, but I also suffer and have since childhood, depression. And it's very difficult for me to answer these questions because at any given time, I could become disabled. And so the implication that I could become disabled bothers me when I answer these questions. But I've been under treatment since before I got, went to medical school. There have been times where I've had to take time off because of my symptoms, but then I take time off. So it's self-regulating. I feel an invasion of privacy when I get asked these questions. It's very personal. To me, it seems like, the volunteering of the information about things that still are stigmatized, even though we're trying to destigmatize it, is different from, the information gathering. So to self-reveal these is different from the board wanting to know what's going on. So I would like to see a separation of the announcement, please be sure to get treatment if you feel impaired, as an attestation on the license application, and then use survey information to find out what the health of the population is of the physicians. I would desperately like to see a separation. If you want to know what the physicians are going through, then do surveys. Don't use the board or the license application to find out what the health is. It's just not fair to ask, because then you have this personal revelation component of the application. But to certainly remind people, hey, if you have a cold and you're not thinking right, stay home and don't try to make medical errors when you go to work. That just makes sense. If you feel impaired, don't work. That makes sense to remind people on the application.
30 seconds remain.
So that's my soapbox, is take off all questions and just do an attestation. Do the questions on a survey. That's
Thank
all.
you for your public comment. Next up here we have Max Bloomberg. Max, you should be receiving a prompt on your end.
Morning. Can you hear me?
We can, Max. Please go ahead.
Thanks. I'm Dr. Max Blumberg. I practice occupational and environmental medicine at the University of California, San Francisco. I would like the medical board to change the impairment section of the license application because, as it is currently written, it stigmatizes individuals who have mental illness, and it also stigmatizes seeking treatment. I would advocate for language on the application that encourages treatment so that physicians are not afraid to get the care that they need. 40% of physicians are reluctant to seek treatment due to fears of punishment from the board, and these fears contribute to patients losing one doctor to suicide every day in the United States. Last year, in a similar meeting to this, a member of the Board of California insisted that these questions were necessary to, quote, catch bad physicians. This harmful assertion suggests that individuals who have a mental health concern, even if they are being effectively treated, are harming patients. Instead, we all know that patients do better when doctors are well, and protecting patients also includes protecting physician well-being. Mental illnesses such as depression, anxiety, and others are not equivalent to and should not be lumped in with substance abuse, which is the case on the license application and has occurred in several of the presentations today. We must do better to allow our physicians who have both substance use concerns and mental illnesses to get the help that they need. I am an alumni of the UCSF training program, and I've been involved in this work for several years through the Committee of Interns and Residents, SEIU. Respectfully, it's time for the board to stop having sessions like this and act. Thank you.
Thank you for your public comment. Next here we have P. Sabaro. You should be receiving a prompt. Looks like your line's open. Are you there?
Yes, I am. Can you all hear me?
We can. Please go ahead.
Thank you very much. So I want to apologize for having not circulated my comments to the medical board by Friday, July 19th, as previously requested. My comments will take no more than 2 minutes. Esteemed members of the medical board of California and members of the public, I have no objection to any of the questions that were circulated on this morning's agenda, and thank you for your scrupulous attention to this topic. At the same time, I am concerned that there are practitioners who are impaired and may potentially not be able to safely practice medicine despite having answered no to the 3 questions posed. In particular, I'm concerned that there are practitioners who have never received an affirmative diagnosis of impairment. My concern stems from the fact that some of the most troubled practitioners will never seek out professional help and obtain a diagnosis. Therefore, many times, impairment or lack of fitness to safely practice medicine because of mental, emotional, or behavioral issues has to be interpolated from other findings, including determinations made by colleagues, supervisors, or assessors who have worked with and/or evaluated the practitioner. Their most likely response to a physician with apparent mental, emotional, or behavioral issues, someone who in their considered judgment is putting the safety of their patients in jeopardy, would be to dismiss this physician from their program or facility. I am worried that to not consider their actions would prevent us from accessing some of the most critical information required to make an informed decision about a licensee's potential impairment. Our goal here, of course, is to protect consumers and members of the public. A system where impaired practitioners can just check boxes answering that they are not impaired doesn't most effectively do that. Therefore, to address these concerns, I invite the board to consider asking applicants these 3 additional questions, which could form the basis for further inquiry by the MBC. 1. Have you ever been involuntarily dismissed from a United States academic, residency, or fellowship program related to the practice of medicine? 2. Have you ever had your privileges at a United States hospital or medical facility involuntarily restricted, suspended, or terminated? And number 3, have you ever sought but been declined any type of professional certification related to the practice of medicine? Answering yes to any of these questions would not disqualify a practitioner from practicing medicine, of course, or from being granted a license. It would merely point the way to additional investigation. I don't believe that any of these 3 additional
30 seconds
questions.
remaining.
Got it. I'm just about done. I don't believe any of these 3 additional questions should trigger any of the concerns related to burnout or potential stigmatization that Mr. Statz, Dr. Ryan, and Ms. Luca so eloquently presented on. Thanks for giving me an opportunity to speak.
Thank you very much for your public comment. Next up here, we just have V identified. It's V. V, you should be receiving a prompt on your end.
Thank you.
Morning, V. We can hear you.
Hi, thank you for having this topic. It's very important. First, I would like to say that 2009, a doctor that was burnt out and probably should have had trauma therapy to deal with all his stress did a medical error on me, and I was unable to sit for 3 years and had 20 injections for pain. So not addressing it. I'm not saying he shouldn't have a license, but he should have had treatment. Not addressing that has cost me 15 years of my life because one thing led to another to another. So if he received proper treatment, I would have a whole different life. Although I don't know what to put in these questions, I want to say that it wasn't until last year that trauma-informed care curriculum was introduced from the medical system, the medical students, and we don't use trauma-informed education, and probably 100% of the doctors have trauma, and we're asking them to get treatment, but it's not addressed through the trauma lens. And trauma therapy is much different than other therapy, and it helps process all their experiences because they have had stress from the time they're going to school as a very young child that has built up and built up and built up and built up. And trauma therapy would help that much more than a lot of the therapies currently offered. And lastly, I had many things affect my mental health. And every time I went to the doctor, I was prescribed pill after pill after pill, when sometimes it was my gut-brain axis or being over-medicated or all the trauma, and I was never properly diagnosed in the medical system. So you're asking doctors to go to the medical system to get help when there's significant gaps in the medical system. And I have done lots of research on PubMed. I navigated it myself. I presented it to Congress, all the gaps. So if you want them to go get help, we need a medical system that actually works, that's trauma informed, understands trauma. And Dr. Bremer, who would look likely had a dorsal nervous system due to all the stress and COVID, if she knew what I knew about trauma, she would know that that was easily curable with trauma therapy, and she might still be alive
30
today.
seconds remain.
So by not properly educating the doctors, we're ending up with suicide. Thank you.
Thank you for your public comment. Next request here is from Stephanie Simmons. Stephanie, you should be receiving that prompt on your end. Morning, Stephanie. Looks like your line's open.
I'd like to thank everyone here for the opportunity to speak, and to thank the speakers who have so eloquently presented this case already. My name is Stephanie Simmons, and in addition to being a trained and boarded emergency medicine physician, I am the Chief Medical Officer for the Dr. Lorna Breen Heroes Foundation. I want to let you all know that the issue of licensing and credentialing concern was one of Dr. Breen's primary concerns at the time of her death. And unfortunately, she is not alone. That we hear daily and weekly from healthcare workers across the country, and unfortunately also their surviving family members who have either not sought care or who have died by suicide because of the fear of losing the careers that they have dedicated decades of their lives to the privilege of caring for patients. Our goal is that healthcare workers are able to seek care for any mental health or substance use disorder so that they can have fulfilled healthy lives and also provide safe access to mental health and physical health care for patients across the state of California and across the country. So one in five Americans, and about 20% or a little less than 20% or 17% of Americans have a mental health disorder or substance use disorder. And healthcare workers as human beings also have that percentage of mental health issues and substance use disorder. We need treatment so that we are able to provide excellent care and to live out our mission and goals of being healers. So I want to thank first the California Medical Board for the changes they've made so far in removing that lifetime look back on diagnosis and treatment. We as a foundation started the Champions Challenge badge as a way to recognize states that had made that change. And in the intervening years, we have learned so much from healthcare workers, from state medical boards, from associations about what is important to healthcare workers, what is important to patients, and what helps improve access, not only from state physician health programs, but also from the peer support programs, the confidential mental health programs in states.
30 seconds remaining.
And peer support. And those are to ask questions that are simple, positively worded in terms of an attestation, and that treatment, including treatment in confidential treatment programs, is not required to be disclosed. So I would encourage the medical board to make those changes. And the Lorna Breen Foundation has submitted formal comment in conjunction with the All-In Tier 1 collaborators, including the American Medical Association, the American College of Emergency Physicians, Medicine Forward, and the Physicians Foundation. Thank you.
Thank you very much for your public comment. Next up here, we have Alicia Sanchez. Alicia, you should be receiving that prompt on your end.
Great. Can you hear me?
We can. Please go ahead.
Okay, great. Good morning, everyone. Alicia Sanchez, representing the California Medical Association. I'd like to first acknowledge the board taking such quick action to convene this task force after the discussion at last month, or the last medical board meeting that you had relative to AB 2164, the bill that we're co-sponsoring related to these questions, and really taking an in-depth look and getting such good and helpful presentations to help on your deliberations. At the beginning of the comment period, you asked whether we would want changes to the question, and the answer to that is yes. We've submitted our suggested amendments via the letter the letters that were requested by last week. I would highlight the fact that the data that many of our fellow witnesses have referenced that don't change. I mean, the physicians have a higher rate of suicide than the general public, and we know that the questions can make it less likely that physicians seek care that they need, and that ultimately is in contravention to what the board is seeking to do, which is have physicians who are well practicing. And so we would like to see the first question eliminated and amendments made to the second question to really highlight the board's emphasis on seeking care, and that be the underlying goal is emphasizing to physicians that they can seek care, and that by seeking care, they will not then necessarily be investigated or disciplined by the board. So again, our specific edits were submitted via our letter, and we would just really want you all to hold as kind of your guiding light the goal of encouraging physicians who feel that they need support to seek out the care that they should get, and not discourage them or further stigmatize seeking care. Thank you so much for the discussion today, and we look forward to working with you in the future.
Thank you for your public comment. Next here we have Kimberly Turbin. Kimberly, you should be receiving a prompt on your end. Morning, Kimberly. Looks like your line's open.
Okay, hi, I am Kimberly Turbin. I am a volunteer with Consumer Watchdog, and I am from Stockton, California. I continue to struggle with the idea that somehow physicians should be given different privileges than others that work with the public. When applying for a job at AT&T, you are asked to disclose if you have a condition that substantially limits one or more of your major life activities. You must disclose whether you have an alcohol or other abuse disorder. You must also disclose epilepsy or other seizure disorders, which falls under physical conditions on your licensing application. You must disclose mental health conditions as well. Now, why would it be more important for someone who either sells phone equipment or provide some form of customer service to provide this information, while you are moving to ensure that doctors do not have to provide this information to you. Physicians are not superior beings. The difference between their jobs and our jobs is that they have our lives in their hands. Therefore, you need to have this information. Do not remove the drug and alcohol substance abuse program or impaired practitioner program questions from the physician licensing application. And do not revise the other two questions that would require physicians to disclose physical and emotional conditions. As a board that was created to protect consumers, you should want this information. Thank you.
Thank you for your public comment. Next here we have Kim Stone. Kim, you should be receiving a prompt on your end.
Stone of Stone Advocacy on behalf of the California Orthopedic Association. The COA thanks the medical board for reviewing the questions. We have submitted written comments urging the board to not require disclosure of problems that do not impair the ability to practice safely. We align our comments with those of the California Medical Association and urge the changes they suggest. We think this is the best way to protect patients. Thank you all very much.
Thank you for your public comment. Next up here, Alice Serenska. You should be receiving that prompt there.
Hello, are you able to hear me?
We can, Alice, please go ahead.
Good morning, and thank you for the opportunity to participate in this important discussion. My name is Alice Serenska, and I am a second-year medical student at Stanford University, where I participate on the leadership board of the Addiction Medicine Interest Group. I also serve as a member of the American College of Physicians, the California Medical Association, and the Committee on Government Affairs of the California Society of Addiction Medicine. But I am speaking to you today strictly as a personal stakeholder directly implicated in this issue, as I myself am in long-term recovery from substance use disorder. I got sober in 2015, the year after I moved to California. At 18 months sober, I started taking classes at City College of San Francisco. After 3 years there, I transferred to finish my bachelor's degree at Stanford, where I have remained for medical school. As a low-income Californian, I have received scholarship assistance to fund the entirety of my education. It is my greatest hope to remain here for the duration of my career so that I can work to repay this gift, both in taxes and in service, to the community that has helped me to rebuild my life. As a trainee physician with lived experience of both addiction and continuous sobriety, I have tremendous potential to give excellent care to my future patients. However, the questions currently posed by the paperwork for medical licensure subject applicants like me to undue scrutiny. Although language specifies that affirmative responses are not inherently disqualifying, inquiring about participation in recovery programs implies that the proactive maintenance of physician well-being is suspicious enough to warrant further investigation. My ongoing attendance to a recovery program is not a liability to my safe practice of medicine. It is in fact the foundation of my trustworthiness and integrity. It is my strongly held opinion that the first question in the application for medical licensure is needlessly prejudicial toward physicians in recovery, and I suggest that it be eliminated. It is wrong to misdirect oversight toward physicians who access supportive resources, and especially so at a time when our state is in dire need of healthcare workers, particularly those who are likely to give competent and compassionate care to our patients with substance use disorder. At worst, this may even compel applicants to lie about their responsibly upheld recovery, seeking to avoid penalty or baseless distrust. The ripple effects of such policy choices are catastrophic. They stand to foster a culture of secrecy and shame, both between physicians and the medical board, as well as between colleagues. I thought for a long time about whether or not to publicly identify myself as a medical student in recovery from addiction, as I am aware of the stigma sober physicians face, as well as the possibility of damaging my blossoming professional identity. But a core tenet of my recovery is being of service to others, which has inspired both my chosen career as well as my decision to come forward with this statement. I am alive today because others believed in me. Thank you, I acknowledge the timer. I am alive today because others believed in me, and I would be doing such privilege a disservice by not using it to advocate in turn for the incredible capacity of other physicians like me. I would be overjoyed to provide my contact information if I can be a resource to anyone who would like to speak further about this topic, and thank you very much for allowing me to contribute to the conversation.
Thank you for your public comment. Next up here, we have Kathleen Soriano. Kathleen, you should be receiving that prompt.
And
Good morning, Kathleen. Looks like your line's open.
Can you hear me okay?
We can, Kathleen. Please go
Great,
ahead.
thank you. Thank you so much. Yes. Good morning. Kathleen Soriano on behalf of the University of California. UC appreciates the opportunity to provide input on this important issue. We request a revision to the mental and physical health question on the applications for postgraduate training, initial physicians and surgeons, and renewal licenses. The current application language discourages physicians from seeking medical care for psychiatric and substance use disorders due to fear of negative impact on their career. In order to protect the health of our physicians, it is critical to create an environment in which physicians feel supported to seek medical care. Having a healthier workforce will promote patient safety, improve the retention of physicians, and increase the access to high-quality care. Following the guidelines released by the American Medical Association and the Federation of State Medical Board, we recommend this single question. Do you currently have any condition that impairs your ability to practice medicine safely? Please respond no if you have any condition which does not impair your ability to practice medicine safely, or if you have any conditions for which you are receiving appropriate treatment and which, as a result of the treatment, the condition does not impair your ability to practice medicine safely. We also recommend that the medical board regularly and broadly advertise resources and anonymous services to assess and treat mental health and substance use disorders. Thank you very much for this opportunity to share our recommendation.
Thank you for your public comment. Next up here, we have Tracy. Give me a second, Tracy, to send you that request. Seeing a couple more call-in users join by phone line as well. Call-in users, in addition to raising your hand and using the Q&A window, you can press *3 in order to toggle raising your hand if you're looking to make a public comment. Tracy, you should be receiving a prompt on your end to unmute. Come on, Tracy,
Hi.
it looks like your line's open.
Okay, hi, I'm Tracy Dominguez, and I am from Bakersfield, and I am a volunteer with Consumer Watchdog. My daughter died tragically due to negligence, lack of care, lack of diagnosis at the hands of a repeat offender. There was so much information about this doctor that my daughter and I did not have the right to know about. So you better believe that I have something about to say about all this. What I found out troubled me that my cousin is a border control agent supervisor, and he requires to answer the questions about substance abuse and any physical, emotional, and mental condition that limits his ability to serve as a border control agent. But in his job, they'll even take it a step further. Each agent undergoes a polygraph test where they are asked if they are a substance abuser issued or physical problems issued, and must respond to the question while the test is being administered. So the question I have is for you is, why should doctors be able to hide these conditions from the board? We always say that doctors are held to a higher standard, but instead you want to have no standards. Please keep the questions as they are. Thank you. And this death, my death, is very personal to me. Thank you, guys.
Thank you for your public comment. Next up here, we have April Dozal. April, you should be receiving that prompt on your.
Hello?
Good morning, April. Your line's open.
Yes, hello. My name is Abril Dozal, and I'm with the Committee of Interns and Residents, SEIU. We represent 82% of the resident physicians in the state, and I want to open by thanking the medical board for prioritizing this issue after the last board meeting. So CIR's ask is simple. We want the licensing questions to encourage mental health in treatment instead of stigmatizing it. Our members have shared that they fear seeking treatment because they worry that they will have to report it to the medical board and that their licenses may be impacted. Some have reported even being actively discouraged by their superiors from going to therapy. And the data supports this. 50% of trainees report reluctance to seeking mental health treatment due to licensure closures, although 1 in 4 interns report having suicidal thoughts. We believe that the board has the opportunity to change the stigma in the culture of medicine by changing the way it asks about applicants' conditions. That is why we're asking the board to change the second question in the impairment section of the application so that it explicitly states that conditions under treatment don't have to be reported and or names that physician wellness is important for patient wellness, thereby seeking treatment is part of keeping patients healthy. Thank you.
Thank you for your public comment. Next request here is from Maria Barra Navarrete. You should be receiving that prompt on your end.
My name is Maria Ibarra Navarrete. I am from San Jose, and I volunteer with Consumer Watchdog. My gravely disabled brother died tragically in an emergency room. He was diagnosed with sepsis, but was allowed to wander off. No one knew where he was, and he was later found unconscious on the bathroom floor. He was giving a medication that was a contraindication to current medications he was on. During resuscitation attempts, my brother died on that restroom floor. For 15 years, I have served communities on behalf of FQHC clinics as a registered dental assistant. In order to become credentialed and remain credentialed, I was responsible for answering very similar questions that you are trying to remove or critically revise from the physician's licensing application. I had to complete credentialing every 2 years as to whether I had a substance abuse issue currently or in the past, and I had to respond to whether I had any emotional or physical impairment that would limit my ability to perform my duties as a registered dental assistant. Now, why would I have to answer these questions, yet my doctor or the doctors serving our communities do not have to? Within the scope of my duties as a registered dental assistant, I have limited authority that would change a patient's life that would have led to the long-term harm that my fellow advocates have endured or ended a life like my brother's. Please keep the question as is. Do not remove the first question regarding substance abuse and leave all 3 questions as they currently are drafted. Our lives are impacted with these decisions as well as yours and your families. You, as the board, are required to take action to protect consumers, protect the public. This action is putting us at risk. Thank you.
Thank you for your public comment. Next up here, Christina Bildering. You should, Christine, you should be receiving that prompt on your end. Good morning, Christine. It looks like your line's open.
Can you hear me?
We can. Please go ahead.
Hi, my name is Christine Bilderain. I'm from Reseda, and I'm a volunteer with Consumer Watchdog. My son died tragically from medical negligence due to an ignored infection, which left him in septic shock. My son also died due to patient abandonment at a local children's hospital. We, as parents, are left in a situation fighting for our children's lives. We can't fight to protect our children alone. We expect you to do your job to collect information and provide us with some information in order for us to protect our families. This move by this board to require even less transparency for doctors to disclose critical issues that is linked to patient harm and patient death is absolutely shameful. Why is it that licensed hemodialysis technicians must answer questions on their licensing application as to whether they have a substance abuse issue? Dialysis techs also must answer the question whether they have a physical or emotional condition that could limit their ability to perform their job on their licensing applications. I have spent many years with hemodialysis techs, so I understand how important their job is, but the real decision makers are the physicians. It was physicians that delivered my son a death sentence, ending his dialysis treatment. You cannot have separate rules for doctors while nurses and dialysis techs and other healthcare providers must disclose this critical information. Please do not remove the substance abuse question and keep the remaining questions in their current format. You are responsible for consumer protection. The only way that you can adequately protect consumers and their doctors is by keeping the questions in their current format. Thank you for your time.
Thank you for your public comment. Next request here is Michelle Montserrat Ramos. Michelle, you should be receiving the prompt on your end. Morning, Michelle. Looks like your line's open.
I am Michelle Montserrat Ramos, and I'm with Consumer Watchdog. As you know, my initial advocacy work was dedicated to this issue, substance abusing doctors, and the transparency surrounding this issue. This issue is very personal to me because I lost my husband-to-be at the hands of a crack cocaine addicted doctor. Everyone knew who he was. This board knew of his addiction problems. The staff at the hospital covered for him. The nurses were angry because his addiction led to so many other failed surgery, like Lloyd's. Yet somehow this board has taken a complete turnaround and feels that it is your job to protect the image and livelihood of an addicted doctor over our lives and our families' lives. This is an incredibly sad state of affairs because disruptive physicians' behavior kills our families. One of our new advocates, Kelly, is here today. She was a charge nurse for many years, and she had to answer the same question regarding substance abuse and if she had any physical, emotional, or mental condition that would impair her ability to do her job as a nurse on her nursing licensing application. Another one of our nurse advocates, Susan, who could not be here today, she stated that she had to answer questions to declare if she had any substance abuse issues. And like Kelly stated, she had to take a drug and alcohol test before every new nurse assignment. Regarding the question if a physician should have to disclose a physical condition, I have an advocate who could no longer walk following her failed spinal stimulator implant surgery. What she didn't know was that her surgeon had an epileptic condition that causes seizures. You, the medical board, knew of this and issued him a probationary license to practice medicine as a neurosurgeon due to his medical condition. The patient had no right to know that her neurosurgeon had a condition that could directly impact her care. Now you are telling us that you don't want to know either. Why don't you want to know if our doctors have these conditions that could either end our lives or could leave some of us unable to walk on our own for the rest of our lives? I shouldn't have to remind you, but I will. This board was not created to merely license and protect doctors. You are required to provide consumer protection, and these latest actions of yours, including trying to remove the substance abuse question and critically revise the physical and emotional issue questions on the physician licensing application, is not protecting consumers at all. You have no idea what medical negligence survivors and their families must endure.
30 seconds remain.
You have no idea how many near suicides that I have had to help with families that have struggled to survive our tragedies. We expect more from this board. We're not going anywhere. Keep the questions as is. It is not stressful to doctors to have to answer these questions. You're choosing to not want this vital information. It's not stressing out Californians. It'll cost more innocent lives. Keep the questions as is. Thank you.
Thank you for your public comment. Next up here, we have Aaron Molenberg. Aaron, I'm sending you that prompt right now. Good morning, Aaron. Looks like your line's open.
Okay, thank you very much. This is Erin Mullenberg. I actually had a question that was directed to the panel, and I just wanted to know, I'm a medical staff attorney that represents several of the medical staffs throughout the state and actually throughout the country, and we're very familiar with what's going on, extremely familiar with the issues of physician suicide and the concerns that are there. With the changes in the questions, and we applaud the Lauren Breen Act, and appreciate what's going on. With the changes in the questions, though, what we do see is that there's more of a burden placed back on the individual hospitals and the medical staffs to help monitor their members and to work with them to enter into localized physician or provider well-being committees, physician health programs, whatever it is, so that they can get their needs met. And also we're trying to campaign for education to our providers to let them know that they need to be seeking the help that they need. But more importantly, what I was seeking was to ask the panel, what are the plans and what are we doing to promote or obtain federal legislation, state legislation to extend the privacy protections for medical information to the questions asked by medical boards, asked by PHPs, most importantly to those asked by the hospital well-being committees. Is that anything that's being done? If not, is that something that you as a group can advocate for? Thank you very much.
Thank you for your public comment. Next up here, we have David Cam. David, you should be receiving that prompt. Give me that prompt one more time, David. There we go. Looks like your line's open.
David Kahn. I'm a psychiatrist and I'm the past president of the California Society of Addiction Medicine, past chair of the Physician Wellbeing Committee, and also a provider of treatment for physicians who are on probation with the medical board. I identify as primarily as an addiction psychiatrist. What I would strongly encourage you to consider is that confidentiality and consumer protection are not incompatible. And for the physicians whom I work with substance use disorder, number one, they're not aware of many of the resources available to them. But the biggest concern that they had before getting into issues with trouble was that they were fearful that their medical license would be affected in some ways. I applaud the medical board for looking at this question in an expeditious manner, and I would recommend following the recommendations of Federation of State Medical Boards. In addition to that, following the recommendations put forth by the California Medical Association to move towards attestation. And I would strongly oppose question 1 being asked because it's stigmatizing. And certainly if physicians need the help, they would be afraid to get it because come the next round of licensure, they would then have to report this. So providing confidentiality for physicians and working through an attestation process would actually improve consumer safety overall. Thank you.
Thank you for your public comment. Next up here, we have Marion Hollingsworth. Marion, you should be receiving that prompt. Morning, Marion. Looks like your line's open.
I think the question should be more exact.
Marion, if you could come a little closer to your microphone, we're having a hard time.
Okay, thank you. Is this better?
Slightly.
Okay.
Yeah, just as loud as you could would be great. Thank you so much.
Good morning. My name is Marion Hollingsworth. I'm a patient safety advocate. I think the questions should be more exact and that doctors should face discipline if they are found to be lying. If doctors are routinely dishonest about practicing while impaired, how do you know when they're being honest with questions? Don't they lie every day when they use drugs or alcohol? A case in point is Dr. Bradley Hay, now former anesthesiologist at UCSD, who admitted to using while treating 800 patients. He was in and out of rehab for years. He said UCSD knew but covered up until he OD'd in a hospital bathroom. So at what point is a doctor considered dangerous? You shouldn't wait until someone is harmed or killed before acting. Is a slight impairment acceptable? And if so, who determines if a doctor is safe to practice if the addiction is kept secret to preserve reputation and keep a practice going? Shouldn't a yes answer be cause for an evaluation? By allowing impaired doctors carte blanche to practice, you are violating your own mission statements, which is to regulate doctors to protect consumers. Please put patient safety before when you consider these questions and not the financial or emotional states of the doctors. Thank you.
Thank you for your public comment. Next, we have here Edwin Kim. Edwin, you should be receiving a prompt on your end. Morning, Edwin. Your line's open.
Good morning. Can you hear me?
We can.
Excellent. My name is Dr. Edwin Kim. I'm representing the Federation of State Physician Health Programs, a nonprofit member organization representing 50 state physician health programs that meet criteria as programs supported by organized medicine in their state and authorized to serve as a therapeutic alternative to discipline. The FSPHP acknowledges the positive effort exerted by the Medical Board of California and examining the role of health licensure question reform with questions that protect consumers and the public, balanced by minimizing stigma that prevents licensees from seeking or getting mental health treatment. Unless posing a specific risk to the public in terms of impairment, physicians and trainees need confidentiality to promote and even drive referral for treatment for any medical or mental condition upstream of impairment. We encourage the board to recognize that illness does not equate to impairment. We have provided a few important references that support this understanding and also support the privacy of medical professionals' health and treatment to encourage physicians to seek mental and behavioral health treatment. FSPHP advocates for compassionate care with the privacy of a medical professional's health and treatment, including confidential participation in a PHP and safe haven or non-reporting provisions for credentialing of compliant PHP participants. It is imperative to provide California physicians and trainees a safe haven when seeking help. To this extent, please find specific comments for each of the three proposed application questions. Consider relocation of question number 1. This question is better suited as dependent to an affirmative response to question number 2. As it stands, the question is unnecessarily stigmatizing and against the efforts of individuals seeking assistance and treatment for mental health and substance use disorders. Amend question 2, possibly to, are you currently suffering from any condition for which you are not being appropriately treated that impairs your judgment or that it would otherwise adversely affect your ability to practice medicine in a competent, ethical, and professional manner? If answered in the affirmative, then ask question 1 or provide education. In the future, if or when a state authorized physician health program exists, add, if you are currently a compliant participant in the state physician health program, you may answer no. We find that question 3 is redundant.
30 seconds remaining.
FSPHP looks forward to being of assistance to the California Medical Board to improve access to care for physicians at risk of mental health, including substance use disorders. Please do not hesitate to contact the FSPHP.
Thank you very much for your public comment. I've got a few more here left in queue we'll be calling on, but anyone who's maybe joined late and didn't hear it earlier, you can use the hand raising feature, the Q&A window, if you haven't already made a public comment, to request to make a public comment. And if you're on a call-in only line, you can press *3 in order to toggle raising your hand that way too, if you're not connected to a computer or mobile device at all. So proceed on here with those left in queue. We have Dylan Elliott next. Dylan, you should be receiving a prompt. Morning, Dylan. Dylan, looks like your line. We can, yeah. Please go ahead.
Great. Hey, Dylan Elliott, on behalf of the California State Association of Psychiatrists. First and foremost, I want to reiterate the thanks to the board for convening this and hearing from stakeholders. Want to align a lot of our comments with those made from the California Medical Association. We were able to submit our written comments earlier this month, and hopefully those have had a chance for review. We'll keep my comments short to that. Again, thank you very much. Appreciate it.
Thank you very much. Next up here, we have Anna Sanchez. Anna, you should be receiving a prompt on your end.
Can you hear me?
Yes, we can, Anna.
Okay.
Please go ahead.
All right. I'm a physician. I'm an OBGYN. I practice in the city of Orange. And I just wanted to expand the conversation a little bit because in hospitals, the word disruptive is used in a different fashion. And sometimes physicians who advocate on behalf of patient care or who blow the whistle on substandard care in the hospital get labeled as being disruptive, which is not the legal meaning of the word, but it gives you a window into the stigma that is associated with having mental illness, especially in the field of medicine. So I wanted to say that if the goal here is to increase patient safety, we need to remember that physicians have the same rights as everybody else. And we have a right to privacy. We have a right to freedom of speech. And anytime that you diminish the constitutional rights of physicians, you are making patients less safe because then they're not as capable of standing up on behalf of patient care. So I think you need to look at hospital bylaws as well, because most people that I know are not so afraid of the medical board questions. What they worry about is what happens in the hospital, because that's where you earn a living. And the bylaws, I don't believe are covered by the ADA, because the Americans with Disabilities Act just covers the employer. So it's like a big black box where they can put in all kinds of stuff that interferes with your right to privacy and can predispose you to unfair peer review. And I'll put peer review in quotation marks. So that I think that is something that needs to be looked at, because I think that's even a bigger problem than the questions on the application for the board. Thank you very much.
Thank you for your public comment. Next up here, we have Kelly Garcia. Kelly, you should be receiving a prompt on your end. Morning, Kelly. Looks like your line's open.
Okay. Hi, I am Kelly Garcia. I'm from El Monte. I'm a volunteer with Consumer Watchdog. My son died tragically in an LA hospital because he was released from the ICU too soon to open a bed. They sent him to a floor gravely ill, and I went in and found him in respiratory distress and called his doctor, who refused to come in and see him because it was the weekend. They would not send him back to ICU or listen to anything I had said. He went to the ER with a stomach ache and never came home. I'm familiar with these processes because I've worked as a charge nurse for many years. As a nurse, I answer similar questions, and I wouldn't have it any other way. We are taking care of people. We have their lives in our hands. We need to answer questions, and we need to abide by them. If you don't take that off and then the doctor does something, you can always say, hey, you signed right here that you didn't have this problem. And then they can be dinged for that. But if you take it off, then they're going to be like, oh, well, I didn't know. I mean, there's going to be an excuse. So please don't take that off. Let them be responsible for something for once. The doctors at the hospital where my son died are being covered by the hospital. They won't let me know if they gave him any kind of recommendation or anything. So in the best interest of our future patients and provide necessary information to our licensing board, the doctors should have to do this. Please keep the questions on the licensing application as it is. If nurses have to answer these questions, doctors should too. Both doctors and nurses are responsible for care, the safe care of patients and their lives. You cannot give preferential treatment to doctors over nurses and other healthcare professionals. I have worked with doctors that all of their patients, the surgeon, all his patients came back with infections all the time. Well, come to find out, he's drinking on the job. I reported it to our director, so I don't know what happened because, of course, it was none of my business. HIPAA.
30 seconds remaining.
But that, I've said about all I could say. I just, please, let's make everybody safe, because it could be your family next. Thank you.
Thank you very much for your public comment. Last year I showed in queue is William Carroll. William, you should be receiving that prompt on your end.
Thank you, everybody, and thank you for creating a space and venue to discuss the application. I'm speaking as a member of the American College of Physicians, and our California chapter as well submitted a written response for this. And our line is really with California Medical Association and California Society of Addiction Medicine. We actually propose some specific language for the question to be rewritten as, do you currently have any condition that impairs your ability to practice medicine safely? Please respond no if you have any condition which does not impair your ability to practice medicine safely, or if you have any conditions for which you are receiving appropriate treatment in which, as a result of the treatment, the condition does not impair your ability to practice medicine safely. We as well, share the concerns of many on this call today and understand that actually having practitioners who are practicing medicine seek treatment for these conditions will make our patients safer and also make the practice environment better. Something that we've also been asking for is actually to have a meaningful physician program for wellness too, which we are only 2 of 50 states that only no longer have this active in California. We used to be a model for the country and actually got rid of this program in its prior existence many years ago and would push for funding for that to actually come back to where it was before. Thank you very much.
Thank you for your public comment. Last minute request here from Lena Cabrera. Lena, you should be receiving a prompt on your end. Morning, Lena. You should be receiving a prompt. There we go. Looks like your line's open. Lena, are you there?
Yes, I'm here. Can you hear me?
Very faintly. If you could come a little closer to your device, I think it would sound better.
Okay. Can you hear me now?
Slightly better.
Okay, great. My name is Lena, and I'm with Consumer Watchdog. And I just have a comment. There is no gray area in whether you have a problem. It's very simple. You either have or had an issue with mental drugs or alcohol problems. May it be 10 years ago, or maybe it was 10 days ago. My fiance walked into the emergency room 4 times within a 4-day period. Before he was admitted, 3 days later, he had a stroke, which made him paralyzed from the neck down. They have to ask us in our patient medical history to determine, what kind of medical history we have. We are the people, we the people should also be aware of the type of doctors who have our lives in their hands. And let us determine if there are any conditions to care for us, our loved ones. We see the white coat and we are to trust them, their decisions, anything that they make to better our health. We trust them because they wear those white coats. My fiance is now paralyzed from the neck down because I trusted their call. When in fact, many decisions that were made in regarding to his health has caused him in his condition today. Doctors and nurses and any type of medical personnel, they eat, they bleed, they sleep, they're human. We're all human. My concern is that we need to keep those questionnaires as is, because like others have said, it is their family that, we trust these doctors. We don't know what their lifestyles are. Their lifestyles can be just like ours. Doctors get DUIs, doctors get divorces, they have sport injuries, they're on medication. We don't know because we're not allowed to ask that. We're not allowed to see up front what they may be taking due to some type of injury, or if they have any type of mental health that, they're going to divorce. We are human. We stress out on everyday life. All doctors are not perfect. We're not perfect. But if we all stick together and like I said, keep those questionnaires as is, because, I don't want to see anybody else go through what we have to go through. Like I said, life is precious and we want to keep our loved ones safe. So I do recommend that we keep those questionnaires as is. Thank you.
Thank you very much for your public comment. At this time, Ms. Jong and Dr. Tsai, I don't see any additional requests.
Thank you everyone for participating in today's meeting. Again, we very much appreciate the 3 presenters coming and taking the time to share their insights. And also thank you to all the other attendees for coming to join us for this very important discussion. We'll consider the information and comments from the presenters and the public when making recommendations to the full board regarding the monitoring and impairment questions.
Thank you, everyone. Thank you to the speakers and presenters. Thank you for all the public comments, and thank you for all the people who attended this meeting. I will call the meeting to adjournment then. Thank you, everyone.